A vertigo patient entering a doctor's office induces vertigo in the doctor itself. The patient will come to you with a huge lot of files, and if you scan the files, you'll find that he has got plenty of prescriptions from different doctors of different specialties from different hospitals and clinics. But all the prescriptions will be limited to prescribing just a few anti-vertigo drugs. Doctors go on changing the brand name of the 4 or 5 anti-vertigo drugs that are available, and the patient shuttles from one clinic to another, one doctor to another, receiving the same prescription with a new name and sometimes with the previous names also. The patient comes home and finds out that this new doctor has given him a drug which he had taken for the last 3 months without any benefit whatsoever. He now ponders, oh, why did I waste my time going to this doctor? You see, all said and done, whatever we are teaching and preaching and presenting at different forums, yet then 95% of patients suffering from vertigo are treated erroneously, injudiciously, unethically, irrationally and unscientifically just by prescribing the anti-vertigo drugs. No matter how much we denounce the anti-vertigo drugs, the reality is that 95% of all patients presenting with vertigo to the doctor get nothing from the doctor other than long continued therapy with these anti-vertigo drugs, that means dimenhydrinate, betahistine, cinnarizine, prochlorperazine, meclizine, and these antiemetics like ondansetron, etc., etc. All these medicines are nothing but symptom relieving drugs. It is just like giving either aspirin or paracetamol or analgin or something like that in a patient of fever, not caring about what the fever is due to. Just like the fever can be due to malaria, due to typhoid, due to pneumonia, due to so many other diseases. Similarly, the vertigo or imbalance can be due to numerous diseases. And just by trying to camouflage the patient's symptom of vertigo by giving these anti-vertigo drugs, the doctor is doing a gross disservice to the patient. This is something which we have to understand and realize that this is not ethical and this is not acceptable. See, science today says that this is detrimental to the patient's health, to the patient's balance system, and it defeats the very purpose of the treatment. But at the same time, the reality is different. So now, let us get into a little more details about all these drugs that are used in the treatment of vertigo and that are so erroneously and unethically promoted by these pharma companies as the panacea and the cure for all types of vertigo. Nothing can be further from truth. And most of these are extremely harmful drugs. So let us go into them one by one. The issue is finding out the least harmful one. The common anti-vertigo drugs that are used are, as we have said so many times, dimenhydrinate, diazepam, prochlorperazine, promethazine, cinnarizine, betahistine, meclizine, and sometimes drugs like ginkgo biloba also. The question over here is not a issue of choosing the right drug, because there is no right drug. The question is on choosing the least harmful one, because all are equally harmful, if not ineffective in a lot many cases. Starting with prochlorperazine. This is one of the most commonly used drugs. Prochlorperazine belongs to the phenothiazine group of antipsychotics known to induce extrapyramidal disorders like Parkinsonism, chorea, acute dystonia with oculozyric crisis, spasticity, opisthotonus, torticollis, laryngospasm, and a lots of other nuisances like this. All are equally dangerous and are extremely harmful to the patient. Its pharmacologically recommended use is only as an antiemetic. It is not recommended as an anti-vertigo drug. Though, of course, nobody would deny that it has got good anti-vertigo effect also. But if you go by pharmacology, it is primarily an antiemetic drug. It has antihistaminic, anticholinergic and antidopaminergic effects. It is the best drug for providing symptomatic relief in acute vertigo, have no doubts about it. For symptomatic relief, nothing could be better. This is the best drug. The vegetative symptoms that accompany acute vertigo like nausea and vomiting are greatly relieved by prochlorperazine. So efficacy wise it is pretty good, but at the same time it is a dangerous drug with lots of adverse effects, and any of these adverse effects can land the patient as well as the doctor into serious trouble. So you have to be very careful when prescribing prochlorperazine. There are too many side effects that all clinicians need to be aware of. The commonly encountered adverse effects of prochlorperazine are oculozyric crisis, blepharospasm, torticollis, then opisthotonus, macroglossia, laryngospasm, and even spasticity. So you see what amount of nuisance and nonsense a drug like prochlorperazine can cause. It will not only land the patient into trouble, but also the doctor who has prescribed the drug. It is not that each and every patient who is being prescribed prochlorperazine will have this. But if one patient of yours has this, and any patient on whom you have prescribed prochlorperazine can very easily have any of these adverse effects. So if any one of them has an effect like this, it is completely going to take away your peace of mind and that of the patient also. So be aware while prescribing prochlorperazine. Extrapyramidal effects like acute dystonic reactions, oculozyric crisis, pseudoparkinsonism and akathisia are the major drawbacks. It is more common in children and adolescents and should preferably be avoided in all children and adolescents. It can cause a life-threatening condition called neuroleptic malignant syndrome. Sublingual preparations sometimes cause local erosive cheilitis of the lips and the tongue. Of course, patients can swallow the tablets in such a situation. It induces orthostatic hypotension pretty often, and the anticholinergic effects of prochlorperazine are often very distressing to the patient. Now come to cinnarizine, another player in the scene of anti-vertigo drugs, hugely promoted by all the pharmaceutical companies, but a drug with too many adverse effects. Let us see them. Of course, it provides good symptomatic relief. It increases the blood supply to the brain and the inner ear. It is not known to have any teratogenic effect, but it has too many side effects and hence best avoided. The common adverse effects of cinnarizine are xerostomia, a dryness in the throat, sometimes a feeling of sore throat, then warm blotchy red skin due to the decreased epidermal thermal dissipation, photophobia, diplopia, that means double vision, and of course mental depression, which is pretty common with cinnarizine, tremor, rigidity and spasticity. You see, there are so many side effects. Akathisia is a very dreaded condition. tardive dyskinesia. Some patients get throbbing headaches, and this is pretty common with cinnarizine. And last but not the least is the worst one, that is side effects like pedal edema, drowsiness, and the worst of all is extrapyramidal symptoms like Parkinsonism, tremor, and anticholinergic effects. All of these are horrible conditions which are not only undesirable to the patient as well as to the doctor, but things like this can completely jeopardize the doctor-patient relationship for life. To ensure that the patient has come to you for some relief of symptoms, you just cannot induce all this nonsense on the patient, and there is no way of knowing which patient will be facing what type of adverse effects. And so it is always prudent to limit using these drugs, and if possible not at all to use drugs like cinnarizine. So you see how much of adverse effects are there. You should also think twice before prescribing a drug like cinnarizine to your worst enemy. Nothing can be worse than this. Side effects like pedal edema, drowsiness, extrapyramidal symptoms like Parkinsonism, tremor, anticholinergic effects, these actually jeopardize the life of the patient and induces a tremendously poor quality of life. So in short, cinnarizine is a labyrinthine sedative. It provides a reasonably good symptomatic relief, there is no doubt on that. It has got good anti-vasoconstrictive effect. It reduces the sludging phenomenon of blood in the narrow blood vessels, stabilizes vascular endothelium. Since it is an anticholinergic drug, it induces CNS depression and hence best avoided, and side effects are tremendous. Pedal edema and drug-induced Parkinsonism, tremor, anticholinergic effects are extremely common with cinnarizine, and so one has to be very, very careful. The next drug in our list is the highest selling anti-vertigo drug today, that is nothing but betahistine. As we had already discussed while presenting on Meniere's disease, is that different studies have shown that it is nothing but a placebo. Nonetheless, it is today the highest prescribed anti-vertigo drug, not because of the efficacy of the drug, because it has been shown to be nothing more than a placebo and is ineffective, but because of the huge advertisement and the aggressive, rather very aggressive, unethical promotion by the manufacturers of these drugs. So let's go into a little in-depth discussion on this highest selling anti-vertigo drug in the Indian market. First, let's begin with the dosage. The dosage is anything between 24 milligrams per day to 1440 milligrams per day. Many people prescribe betahistine even at 600 or 900 milligrams per day, even though the recommended pharmaceutical dosage is not more than 48 or at the most 72 milligrams per day. In fact, the recommended dosage is between 24 to 48 milligrams per day as per pharmacology books. So since there is such a wide variation in the dosage in use, possibly the drug is ineffective, and that is why people have to use such high doses, 10 times higher or 20 times higher than the recommended pharmacological dosage. Betahistine obviously provides some amount of symptomatic relief by sedating the vestibular labyrinth, though nowadays it is being said that it stimulates the vestibular labyrinth. See, these are all sale gimmicks. Science tells us that it is a vestibular sedative and it sedates the vestibular labyrinth. Get this thing clear. Because nowadays it is being said that we should not prescribe vestibular sedatives for more than 3 to 5 days. The promoters of this drug have now started calling it a vestibular stimulant. doctors can very easily be taken for a ride with all sorts of nonsensical propaganda. It increases the blood flow to the brain and the inner ear, no doubt about it. It does not depress the central nervous system. This is the best point of betahistine. It is probably the only non-sedative antivertigo drug without any anticholinergic and antidopaminergic effects. All the antivertigo drugs have got anticholinergic and antidopaminergic effects, which greatly induces adverse effects of the drugs. And moreover, the anticholinergic effects induce drowsiness, and since the vestibular compensatory pathways are usually cholinergic pathways, these anticholinergic drugs jeopardize the compensatory mechanism also. But betahistine is not an anticholinergic drug, and that is the advantage of using betahistine. But of course, it has to be effective. Science says that it is not effective at all. So let us see. But mechanism of action is very confusing and unclear. If any of you are interested in going into details with all the references, you can always visit my website vertigoclinic.in, and there go into the blog page and there find out the hoax of betahistine, and will get a lot of details. The mechanism of action is very confusing and unclear. There are controversies in dosage, as we have discussed. It is not 24 to 900 milligrams only. People prescribe it, and it is promoted even up to 1440 milligrams per day. It has been proved by scientific studies to be a placebo only and without any medicinal effect. You see, if you go into the details of betahistine, you will find that at certain places it is said to be a inverse agonist of H3 receptors, and at certain places it has been said to be a antagonist of H3 receptors. The best action of betahistine is on H3 receptors. There are 4 types of histaminergic receptors: H1, H2, H3 and H4. Of all these 4 types of histaminergic receptors, betahistine has the best action on the H3 receptors. But its action on the H3 receptors is very confusing scientifically. In some places it has been mentioned to be an antagonist of the H3 receptors, and at certain places it has been said to be an inverse agonist of the H3 receptors. There is a heaven and hell difference between an antagonist and a inverse agonist. An inverse agonist actually induces effects opposite to that of the agonist, while an antagonist will not allow any effect to take place. So there is a huge difference. I'll just give you a small example. Supposing there is a drug which, say, induces, the agonistic effect of the drug is to induce vasodilation. The antagonist effect would be to not to induce the vasodilation, but the inverse agonist effect would be to cause vasoconstriction. So there is a huge difference between what an antagonist is and what an inverse agonist is. The problem of betahistine is that in scientific literature, at some places it is said to be an inverse agonist, and in some places it is said to be a antagonist of the H3 receptors. So you see, science is so very confusing. How can we use a drug on which the science is so very confusing? And its actual action on H1, H2 and the H4 receptors is minimal. It does not have much action on the other 3 receptors. The main action, as you said, is on H3 receptors, and there also science is very confusing. You will find a lot of details over here, and in different places it has been shown to be a vestibular sedative, like in this reference, which is from the SERP manual. And that means this is the betahistine manual produced by the company that promotes betahistine in the biggest possible way across the globe. So they will find in the product monograph, it is clearly written that betahistine alters neuronal firing rate in the vestibular nuclei, and betahistine dihydrochloride is found to have a dose dependent inhibiting effect on spike generation of the neurons in the lateral and medial vestibular nuclei, which means that it is a vestibular sedative. It is not a vestibular stimulant as the companies very often promote it to be. It is actually a vestibular suppressant which is shown in the product monograph brought out by the company that promotes this drug. So this is it. Here again you will find that in the product monograph itself it is written that the mechanism of the action of betahistine dihydrochloride is only partly understood. Betahistine dihydrochloride acts both as a partial H1 receptor agonist and histamine H3 receptor antagonist in neuronal tissue and has negligible H2 receptor activity. Betahistine dihydrochloride may increase blood flow to the cochlear region. See, so even the company is not sure whether it actually increases the blood flow or not, though there are some studies which have shown. We'll come to that. Yet then, in the product monograph itself, it is written that betahistine dihydrochloride may increase blood flow to the cochlear region. So, if the company itself is not sure about the action of the drug, how can we be sure about it? This is ridiculous. So, when we are doubtful on whether the blood flow really increases or not, and if we are really interested in increasing the blood flow to the inner ear or to the brain, then it is wiser to use a drug that is known and that is established to increase the blood flow to the neuronal tissues in the brain. And for that we can use some other drug like pentoxifylline, clopidogrel, then aspirin, etc., etc. There are so many choices. You can use a drug like complamina if you are actually wanting to increase the blood flow to the brain, because these are sure shot successes and these are known and established to increase the blood flow to the neuronal tissues in the brain and into the special sense organs. See, here you will find that this is from one of the best articles on betahistine written by Michael Lacour. This is one of the topmost names in the pharmacotherapy of vertigo, especially on betahistine. He has done a huge lot of work on betahistine. So this is from a publication of his. Here it has been shown that betahistine decreases the vestibular input. It is very clearly written here. And here in the 2013 study, he has shown that betahistine is a H3 receptor inverse agonist. So remember this. So it shows that it decreases vestibular input and it is also an inverse agonist. This is what the 2013 study of Michael Lacour has shown. In a previous study of 2001, same Michael Lacour had shown that betahistine has a antagonistic effect on the H3 receptors. It's very, very confusing. The same author once calling it a H3 receptor antagonist, and 12-13 years later the same person calls it an inverse agonist. As we said, these are completely different entities. So until we know what it is, how do we know how it is going to act? See, all these things are given. It has been shown that betahistine causes inhibition of activity in the vestibular nuclei. Betahistine reduces vestibular input. But vestibular sedatives cannot be prescribed for more than 3 to 5 days as per current consensus. So now the promoters of this company have started touting it as a vestibular stimulant. What nonsense! Are we being taken for a ride? So doesn't this leave us much more deluded? The drug betahistine is not approved by the Food and Drug Administration of the US. Once it was allowed nearly 50 years ago, for roughly 5 years the drug was being sold in the US, but later the approval was withdrawn because it was found to be ineffective, and it was found that the studies that had been submitted for approval of betahistine were completely flawed studies and unreliable studies. So it was approved for 5 years. That also was 50 years back, but since then it has not been approved and it is disapproved by the US FDA. So these are things about which we should all know before prescribing betahistine left, right and center. A review suggested that presently it is still unclear if betahistine has any effect in Meniere's disease. This is from the James and Burton study, 2001. It was reviewed by the Cochrane database in 2009, which concluded insufficient evidence to prove its action. A recent study on eye drops also found betahistine has no effect by Gurlov in 2012. It is currently not approved by FDA for use in US. See, these are things which are important. If you go into the dizzinessandbalance.com site of Timothy Hinn, he has very specifically written that evidence is weak for betahistine being an effective treatment for Meniere's disease. Our guess is that it is mildly effective and fortunately it has few adverse effects. So this is what the drug is all about. Now it is touted and promoted, and a lot of propaganda is there saying that betahistine increases the central and inner ear blood flow. Yes, it does, but there is a catch to it. The increased blood flow is of course known to be due to its H1 and H3 receptor effect, but the much hyped H1 agonistic action is pretty weak, and this action of increasing the blood flow was observed only at levels which were 100-fold higher than the therapeutically recommended dose. And so in the therapeutically recommended dose, it possibly does not induce significant improvement of the cerebral and inner ear blood flow. Moreover, this action is negated by the antihistaminic group of drugs because betahistine is a histamine analog, and usually, of course it is not very ethical, many doctors combine an antihistaminic drug like prochlorperazine or cinnarizine with betahistine. So it is basically combining an antihistaminic with a histamine analog, which is not scientifically correct. Now coming to the question of the role of betahistine in vestibular compensation. Yes, betahistine has been shown to enhance vestibular compensation and facilitate recovery of balance function. The study that is quoted is a study by Tiglit in 1995. Very true. But this study was on cats and this is not a human study. And the dose used was also 100 times the recommended dose for humans. So, how relevant this is in clinical practice is difficult to say. These are all hyped up propaganda which may or may not actually have any clinical significance. BMED study, which we had already referenced a bit earlier, has shown that it is nothing but a placebo, and the results of using betahistine at a low dose of 48 milligrams per day, which is the recommended pharmacological doses, and at a high dose of 144 milligrams per day for 9 months continuously, have shown no difference from the effect of a placebo. And so this drug is actually established to be nothing but a placebo only, nothing more than that. So the Cochrane review for betahistine has shown that there is insufficient evidence to say whether betahistine has any effect. This very authentic study on the efficacy and safety of betahistine treatment in Meniere's disease, which is a multicentric, double-blind, randomized placebo-controlled study, has shown that in 3 groups of patients when betahistine was administered, one group receiving 48 milligrams daily for 9 months, another group receiving 144 milligrams daily for 9 months, and another group receiving just a placebo for 9 months. When their effects on patients of Meniere's disease were compared, it was found that there is no difference between using betahistine for such a long period at 48 milligrams per day or at 144 milligrams per day or using a placebo, which means that betahistine, even up to doses of 144 milligrams per day, is in no way different from that of a placebo. And so the bottom line of this study is that betahistine is nothing but a placebo. Next we come to dimenhydrinate. It is a conventional antihistaminic with high anticholinergic effect. The mechanism of action is as follows. It inhibits the spread of the hyperactive vestibular input via the medial longitudinal fasciculus to centers for vegetative regulation in the medulla. That is the centers for heart rate, respiration, vomiting, sweating, etc. Which means that if a patient is having severe vegetative symptoms along with the vertigo, like say severe vomiting, nausea, sweating, tachycardia, etc., then a drug like dimenhydrinate would be very effective. It would not only reduce the vertigo but would also take care of these vegetative effects. So this is the right drug to choose in patients of acute vertigo who are having pronounced vegetative symptoms. And the biggest advantage of using dimenhydrinate is that it does not have the extrapyramidal features, or it does not have the adverse effects of inducing extrapyramidal features which drugs like prochlorperazine, cinnarizine, etc. have. So this is a big advantage. See, any drug that you give for the vegetative symptoms like prochlorperazine, be it cinnarizine, or drugs like say metoclopramide or ondansetron, all of them induce extrapyramidal symptoms. But dimenhydrinate takes care of the vegetative effects, but it does not induce any extrapyramidal features. So this is a very big advantage and it makes the drug safe for use. Of course, it has got certain problems also. It is highly sedative, impairs the psychomotor skills, and concomitant use of alcohol and other CNS depressants should always be discouraged. It is best avoided in patients having enlarged prostate, glaucoma, emphysema, chronic bronchitis, etc. And this applies not only to dimenhydrinate, it applies to all the other anticholinergic drugs like cinnarizine, meclizine, prochlorperazine, etc. At very high dosage, it can affect color discrimination, night vision, visual reaction time, and stereopsis. And so a patient taking dimenhydrinate should always avoid driving a car, especially at night. So this was in short just touching upon the common drugs that are used in vertigo. So to summarize, we can say that the current consensus on management of vertigo is as follows. We need to diagnose the cause of the balance disorder and treat the cause of the vertigo rather than merely try to camouflage the symptoms of vertigo by the eternal continuation of the anti-vertigo drugs. We have to treat balance disorder patients holistically, taking care of the comorbidities like the psychological and cognitive problems induced by the balance disorder. And ethical and rational treatment of vertigo consists of, one is diagnosing the cause, and secondly treating the cause by specific drug therapy and not the non-specific anti-vertigo drugs. This is the number one message, that whenever we get a patient of vertigo, we should try to find out the cause of the vertigo and treat the cause rather than merely try to camouflage the symptom of vertigo by prescribing the anti-vertigo drugs. The maneuvers should be done for positional vertigo. Whatever propaganda is done by the different pharmaceutical companies saying that their drug would cure positional vertigo, this is all nonsense. Positional vertigo has to be treated only and wholly by the different liberatory maneuvers. And the treatment of any type of positional vertigo, of course, if it is a benign paroxysmal positional vertigo, not the central vertigos, not the central positional vertigos, all types of BPPV, benign paroxysmal positional vertigo, should be treated only by the maneuvers. Now, in a very small percentage of patients, you will get something which is called a post positional vertigo syndrome or post BPPV syndrome, where even after the positional vertigo has been completely corrected by the liberatory maneuvers, the patient keeps on having a feeling of unsteadiness. In these patients, there is some scope of giving some anti-vertigo drugs for 2 to 3 days, 5 days at the most. And with it, we usually give some benzodiazepines or SSRIs for about a month or so. And the most effective treatment is vestibular physiotherapy. The general ones like yoga, tai chi, virtual reality, and the organ-specific vestibular physiotherapies, where after being able to diagnose that this particular vertigo is being caused by a defect in the saccule or this particular vertigo is being caused by a defect in the lateral semicircular canal, or this particular vertigo is being caused by a defect in the right anterior semicircular canal, we offer specific physiotherapies which will stimulate only that part of the balance system. That means it will stimulate, if we find that there is a defect in the saccule, we will stimulate specifically the saccule. So these things are now a reality and we can do this very well now. Though this presentation was basically on drug therapy, we have touched upon vestibular physiotherapy here and there. But if you are interested more on vestibular physiotherapy, you can get back to us where we will be giving you much more details on organ specific targeted vestibular physiotherapy. Because this is the newest development that has completely changed the scenario of management of balance disorders. So the take home message is, one is, today the underlying pathology and site of lesion can be diagnosed very accurately in most if not all patients of vertigo. We must restrict the use of symptom relieving anti-vertigo drugs to 3 to 5 days and only reserve it for acute vertigo. That means acute head spinning, never ever for imbalance. Only use drugs that are efficacious and has a logical mechanism of action. Treat the underlying disorder causing the vertigo rather than camouflage the symptom of vertigo. Fourth point is, expedite vestibular compensation through organ targeted vestibular physiotherapy, as this is the only way to restore balance. And lastly, treat the concomitant psychological and cognitive impairment for a complete recovery. So it has been a long day. Thank you very much.